Hello, I'm Dr. Michelle Lorentzos, Paediatric Neurologist and Clinical Trials Medical Lead from Westmead at the Children's Hospitals Network. Our Advanced Therapeutics Webinar series welcomes you, where we focus on the rapidly evolving space that is advanced therapeutics as it prevents innovative and potentially transformative treatments for children now and in future years. Before we get started, I'd like to begin by acknowledging the traditional owners of the various lands on which we are all meeting today. This webinar is being hosted from the traditional lands of the Gadigal and Bidjigal people of the Eora Nation in the east and Barramadigal people of the Darug Nation in the west of Sydney. We pay our respects to elders past and present and acknowledge the community members, Aboriginal staff, services and organisations who work closely with us to improve the health and wellbeing of children and young people, their families and communities. So welcome again to the Advanced Therapeutics webinar of the Sydney Children's Hospitals Network. Today we are joined by a panel of local experts who will provide insight on newborn screening for rare conditions. We welcome Dr. Sandi Kariyawasam and Professor Prof Bennetts from the Sydney Children's Hospitals Network, as well as Dr. Sophy Shih from the Kirby Institute at UNSW. Following their presentations, our panel will be open for discussion, so please submit any questions throughout the webinar via the Q&A tab in the Zoom controls. And if you see a question submitted that you would also like to have answered, you can upvote the question by clicking the thumbs up beside it. Now let's begin with Dr. Sandi Kariyawasam. Over to you, Sandi.
Hello, everybody. I want to thank you all for being here today. I know it's a Friday and end of a long week, but I'm very excited to share with you the results of our long-term outcome study from the first Australian pilot newborn screening program for spinal muscular atrophy. And I'm doing this on behalf of a very wide stakeholder group. So I just want to go back in time together before we go forward and really remind ourselves of why we're having the conversations about SMA that we're having today and how they've changed over the last few years. SMA was previously considered a lethal condition underpinned by irreversible loss of motor neurons from the spinal cord and brainstem. The family here had a child who developed symptoms of SMA, and she was one of the first children to be treated with disease-modifying therapy internationally outside of a clinical trial. And everybody was saying what a success that was. Everybody but the parents, they were so grateful, but they were devastated that this had not been picked up earlier. And why? Because there's a very narrow therapeutic window in which to intervene, whilst you still have a motor neuron pool to salvage. Then in contrast, you have this email from a mother of a child who was diagnosed through newborn screening and given interventions very early on. And this child is developmentally normal. And she writes, as you can see here, what is the bridge in the middle? It's newborn screening. But only 13 countries, and that's about 2% of the world's population, have access to NBS for SMA. As this is the first time a genetic test is incorporated into newborn screening programs, as first here, its addition can really challenge conventional workflows, both in the screening, diagnostic and clinical services. So how do we build an evidence base that NBS for SMA should become the new best standard care practice in Australia and internationally? We looked at this data gap, and then what we did was we designed a study with the aim to investigate the effectiveness of newborn screening for SMA, coupled with access to disease-modifying therapies as an intervention. And we looked at clinical outcomes using real-world data. This was a prospective, single-center, non-randomized interventional cohort study. Lots of words to describe what I'm going to just tell you. This study included newborns, infants and children with genetically confirmed SMA. The intervention group included newborns diagnosed with SMA following a positive newborn screening result. And these children were recruited through the first 2 years of the pilot program, so from 2018 to 2020. And this program ran in New South Wales and the ACT. The comparator group were those who were clinically referred with signs and symptoms of disease, presenting consecutively in the 2 years prior to the start of the Australian pilot program. And that's the way the majority of children continue to be diagnosed across Australia. All children in the study population had the potential to access disease-modifying therapies. So in clinic, what our parents want to know, and I think many of the clinicians in the room will attest to this, is that will my child be able to walk, and how will they function within this world if we access medications? So our endpoints were really informed by what was meaningful to parents. Our primary endpoint was the highest motor milestone attainment using the World Health Organization Multi-Center Growth Reference Study, the WHO scale, at 2 years post-diagnosis. Many of you will have used this scale, but it's an assessment including 6 scaling items of development, right through from sitting unsupported sitting with support through to walking alone, and secondary endpoints as you see there. These are the results of the study, and I hope they'll be exciting to you as they are to me and our team. 33 children formed the study population, 15 in the intervention cohort and 18 in the comparator. And this cohort is really representative of the children that we see coming through in clinic. It's very heterogeneous, with children with different genotypes and functional abilities. The intervention group, of course, was significantly younger than the comparator at diagnosis, therapeutic intervention, and follow-up. In fact, we were able to diagnose children through NBS by a median of 14 days of life and start treatment for them by an average of about 3 weeks of life, just under 4 weeks. The outcomes we are looking at are for children who are around the age of 2 years in the intervention group and nearly 3 years old in the comparator. 3 children went through a palliative care pathway, 1 in the NBS group and 2 in the comparator. We captured some of the earliest signs and symptoms of disease onset, which have very rarely been previously described just because we haven't had this NBS model to capture them. Here you can see that SMA is what I think of as a medical emergency, where the motor unit loss can be very precipitous. This baby came to our attention through newborn screening, and we first saw him in the first few weeks of life, and he was already symptomatic by this stage. He has an ET2 SMN2 copy number, which is a prognostic genotype predicted to have a severe and very early onset form of the condition. And you can see here that he's frog-legged. He's got those typical signs of SMA. When you pull him to sit, he's got that head lag. He has paucity of limb movements. And when Michelle turns him over, he's very floppy. This is telling us that for some, disease onset can be very early on, probably starting in utero. And if you wait for them to be clinically referred through through signs and symptoms of disease, it can take several months. And by that time, it may be too late to salvage a meaningful motor unit pool. Within our intervention group, 40% of them were similarly symptomatic by an average of 18 days of life. So this wasn't just an exceptional case. Survival in our cohorts was 93% and 89% in the intervention and comparator groups, and children in the intervention group in orange reached significantly higher developmental milestones, with 86% of them walking independently or with assistance, and that's around 2 years of age. And this is compared with only 6% of children achieving independent ambulation in the comparator group in blue, despite them being chronologically older. Instead, at an average age of around 3 years, the highest motor milestone achieved in the comparator was the ability to sit, and that was found in about 50% of the population. But what we had to figure out was, is it actually the early diagnosis through NBS and the early access to treatment that is responsible for these significant differences? And here you get a sense of, yes, it is. Here you have age at diagnosis on the x-axis in your left-hand panel, and age of treatment on the right against motor scores over 2 years, evaluated through a validated motor function scale called the HINE, and that's on the y-axis. With NBS for SMA and disease-modifying therapeutic access, we've completely changed the correlation effects for gaining motor function from a negative correlation in the comparator group here in orange to the positive correlation in the intervention cohort in purple. So we can quite conclusively say that yes, NBS for SMA leading to an early age of diagnosis and as a gateway to accessing therapeutics can change the trajectory of your motor function gain with time. So in terms of the evolution of comorbidities, the data shows that the odds of requiring respiratory support and supplemental feeding are 7 times lower in the intervention cohort compared to the comparator. And then we go on to the functional independence. Again, that's so important for families. We use what we call the WeFIM score, and that's a composite score looking at self-care, cognition, and mobility domains. And where you have higher scores when you have better functional independence. And what you can see is that the children in the intervention group had higher WeFIM scores than the comparator. And more interestingly, self-care scores were on par with the comparator group. Remember, the intervention group it's about a year younger than the comparator. So basically, in the intervention cohort, a child at 2 years of age is behaving functionally like a child in the comparator group at 3 or 4 years of age. I think it's really important to match the data that we're talking about to the children that we see in clinic in our practice. And we've seen a spectrum of children graduating to the NBS for SMA program. This is a video of the baby. He's no longer a baby, actually. He's now just over 2 years old that we saw in the video a few slides back. And he was the one who started having symptoms. He's got that 2SMN2 copy number. He has definitely gained skills, but life is hard. He still needs respiratory support and some degree of supplemental feeding. So even though we say NBS is fantastic for giving this early pathway, we still need our children to be integrated into the multidisciplinary clinic so that we can support their changing needs over time. That's really key. On the other end of the spectrum, we have a lovely girl. She is in clinic at 13 months, and here she is taking her first steps, so completely in line with normal development. She has 3 SMN2 copy numbers, and she was pre-symptomatic when she had disease-modifying interventions. So the impact of our work is multifaceted. We've shown that NBS for SMA really reduces that diagnostic and therapeutic delay and is clinically effective for children across the genetic and phenotypic spectrum of the disease. And this paradigm improves motor function, supports functional independence, and reduces comorbidities. Creating this real-world evidence is driving changes in health policy at home, and it's been part of the basis for the federal government to endorse NBS for SMA across Australia. And it is having impact internationally with a lot of the international programs looking to our outcomes to provide an evidence base that this should be best practice, really. So I'd like to acknowledge all the people who took part, mainly the children and their families. And I will now hand over to Dr. Sophy Shih.
Thank you, Sandi. Hi, everyone. I'm Sophy Shih. I am a health economist from the Kirby Institute. Today, I would like to share with you a modeling cost-effective analysis of newborn screening for SMA with disease-modifying treatment. I conduct this study in a dual appointment between Center for Big Data Research in Health and Kirby Institute at the time. So from 2018 to 2022, as Cindy described, the newborn screening pilot program was conducted in the state of New South Wales and ACT to add 2 additional genetic conditions into the existing newborn screening test panel. They are SMA and PID. At the time of the pilot program, what we knew were, firstly, early pre-symptomatic initiation of treatment achieved much better outcomes, as Cindy just demonstrated, shown in her presentation, than clinical symptomatic treatment. There are a number of health technology assessment, HTA reports around the globe from Ireland, Canada, UK, US, and Australia have reviewed the clinical and economic value of nusinersen and gene therapies, including some published modeling study showing that clinical identification of treatment with nusinersen in symptomatic SMA is actually not cost-effective compared to supportive care. Gene therapy, on the other hand, in clinical identified SMA1 is cost-effective, but that is based on the basis of preliminary efficacy data at the time when we conduct the study. However, cost-effectiveness of these disease-modifying therapies in the era of universal newborn screening was limited. Therefore, in 2020, we proposed to conduct a study to answer the study question that whether a statewide newborn screening program for SMA treated with pre-symptomatic disease-modifying therapy more cost-effective than clinical diagnosis with late treatment initiation. So in terms of the cost-effectiveness analysis, we took the analysis from a broader societal perspective to model the cost and outcome for the time horizon of 5 years and 60 years. The main outcome we modeled in our analysis was quality adjusted life year quality, and we use a decision analytic models with Markov simulation to predict the cost and outcomes for the time horizon we define. The main modeling assumption we need to make for the long-term outcome would be the treatment effect sustained over 60 years. And we report the result in 2018 US dollars value with discount rate of 3% per annum. So this diagram basically shows you the 4 comparative alternatives in our economic evaluation analysis. So the first 2 are the intervention with newborn screening, and the first one was pre-symptomatic nusinersen treatment, and the second one is newborn screening with pre-symptomatic gene replacement therapy. And the 2 comparator we choose as a comparison to these 2 newborn screening intervention were symptomatic nusinersen treatment without newborn screening and supportive care without newborn screening. So we developed a Markov simulation model with 11 health states. Basically, this is state simulating the motor milestone development for the baby with impact by SMA from the non-sitter to sitting, to standing, to walking, and walking independently. We also consider the loss of the motor milestone in the Markov simulation for the baby with SMA, with and without treatment. So for the cost-effective analysis framework, firstly, what we did is we compared the 4 possible treatment strategy for one infant diagnosed with SMA and compare the pairwise comparison between these 4 treatments for a SMA diagnosed baby. And secondly, we combine the treatment strategy with newborn screening intervention to assess the cost effectiveness of one newborn in the general population. So the result of the treatment strategy, for each infant diagnosed with SMA, pre-symptomatic gene replacement therapy is cheaper than the pre-symptomatic nusinersen for the same improvement in health in terms of quality gains. If we compare the pre-symptomatic gene therapy to the late nusinersen treatment in clinically detected SMA, you can see that a greater health benefit in quality gains with lower total cost over 60 years. In this case, we call the gene therapy is a dominant intervention compared to clinical diagnosed and treated with nusinersen. Then we embed that treatment strategy of SMA within a newborn screening framework and assess the cost effective for every newborn in the general population. So for each newborn screen for SMA, gene therapy is cheaper than nusinersen in the long term of 60 years for the same improvement in health, but much lower cost over the 60 years for one baby in the general population. And if we compare the gene therapy within the newborn screening to the clinical diagnosed SMA treated with nusinersen without newborn screening, as you can see that the quality gain is much higher than for the pre-symptomatic gene therapy within newborn screening compared to nusinersen treatment without newborn screening. And again, the gene therapy treatment is considered a dominant intervention. So our result is actually highly robust as we conduct a sensitivity analysis shown by this scatter plot of probabilistic sensitivity analysis showing that 77% of the simulated incremental cost effectiveness ratio were under 50,000 per quality, which is a commonly used willingness to pay threshold for considering value for money in healthcare. Or in the dominant dot quadrant, which you can see on the right-hand lower quadrant of the cost effectiveness plan as shown in the green dot, that indicate that intervention is more effective and also cost savings. So there are a number of limitations of our modeling study. Inevitably, we have to make assumption of sustained treatment effect for modeling the long-term outcomes from available short-term trial result. At the time, there were some uncertainty around the gene therapy, both in the long-term effectiveness and the price of the gene therapy. However, our sensitivity analysis and threshold analysis indicate that as the gene therapy cost under the US $1.9 million, then gene therapy within newborn screening program will be a dominant intervention, which is more effective and also cost saving. There are challenges in our analysis in terms of quality of life measures. At the time and also currently, only cross-sectional quality of life measure being collected, and generally they are from older and sicker children, which is not actually a true reflection of the quality of life of the baby in the newborn screening program. And there are also ongoing debates about using a high willingness to pay threshold for rare conditions like SMA. And finally, our result represent the epidemiological profile and clinical decision-making in the Australian settings, which may not be applicable to other countries with different profile. So lastly, I would like to thank the funding from Luminescence Alliance with new support from the New South Wales government and assistance from the newborn screening pilot study. And thanks to all and everyone, all the effort and everyone involved, the New South Wales government has now permanently added SMA and PID to the program following the successful 4 years trial. So from 1st July 2022, parents of all new babies born in New South Wales and ACT are offered newborn screening for SMA. So lastly, I would like to acknowledge the contribution of my research team, including especially Associate Professor Michelle Farrell and Professor Georgina Chambers. So now I hand over to Professor Bruce Bennett. Thank you.
So thank you. And thank you for allowing me to have the time to share this exciting project on the newborn screening trail project. We here at the Sydney Children's Hospital Network are working in collaboration with the University of Sydney and New South Wales Health Pathology and the CSIRO and the Southwestern Sydney Local Health District and PathWest, as well as many other partners in contributing to the newborn genomic sequencing in screening, therapy ready and information for life project, which we will refer to as TRAIL. So thank you to Sandy and Sophie for setting the newborn screening blood spot screening setting through a positive SMA story in New South Wales. And in a way, the TRAIL study is building upon this positive story. We're taking the lessons that we have learned through the SMA pilot and implementation in New South Wales and working nationally with our interstate colleagues to explore the potential of a multi-omics approach as a complement to newborn screening, the existing newborn screening programs. And these are our broad goals that we're aiming to address. Can whole genome sequencing be used in newborn screening? Can it be done at sufficient scale and speed for it to be useful as a primary screen? Is genomic sequencing acceptable to the Australian public? Can newborn screening data be used throughout life? Is it reliable for diagnostic purposes? And is it a cost-effective option for future genetic testing requirements? And very critically, can newborn screening data be stored securely with high-level security and family control? Central to our project are the views of consumers and other important stakeholders, and we'll continuously seek to keep a patient and stakeholder-centric view for all of our work. And we've chosen to take an approach of using genomic sequencing to screen for treatable disorders, as we feel this is the best way to be therapy ready. And in the clinical trials space, that's what we want to be able to do, to be therapy ready. However, there are a number of challenges to this approach that we would like to test. The New South Wales newborn screening program screens approximately 2,000 babies a week. And a key question is whether genomic sequencing, a genomic sequencing approach is viable, and can it be done in a time frame that's needed for newborn screening? And as I said earlier, another major issue is around data storage and security and access. And we all know of recent events involving Medibank and the likes that demonstrate the importance of this. And whilst genomic data is beneficial in the newborn screening period, it's also helpful for many people later in life. And could quick access to this data for health purposes be a significant improvement to patient health? And there are significant costs associated with genomic sequencing, and thus reusing this information makes good economic sense. And all of this is feeding into the expansion of newborn screening. So the TRAIL project comprises of 5 separate cohorts done over a 4-year period. And our first cohort is 1,000 de-identified newborn screening cards. And this is a retrospective study. And the genes that we're going to screen for that are being finalised at the moment. The grant is agnostic as to the gene sets, and we're hoping to take a national approach, working with our national and international colleagues. And there is already an Australian panel app for newborn screening, which has about 500 genes. So the nice thing about this is that this data set can be used for any genes without fear of incidental findings. And thus it's an ideal set to test the technical feasibility of screening for genes associated with potential new therapies. So if someone comes with a new therapy, we can say, yes, we can look at that particular gene and explore it. However, we can't use this data set to explore the clinical implications of testing. You know, what is the clinical burden? What's our false positive, false negative rates, and the acceptability of screening? We're going to have to use other ways of looking at that. Our second cohort is a consented cohort of pre-existing diagnoses. So this is to test the system to actually identify pathogenic variants. So the fortunate thing about this is that there are limited ethical concerns, as the patients will already be under clinical management and will have a genetic diagnosis already. So it'll be retrospective, and we'll be comparing the result that we can get from the newborn screening card with their existing diagnostic testing. And this cohort will be used to determine if screening can be used diagnostically. So can we use this data again in different settings? And the cohort will also survey and capture ethical and social perspectives of whole genome sequencing and newborn screening. And there is a potential low risk of finding secondary findings, so they may have two diagnoses. So we will be looking at that as well. We will not be looking at carrier status because that is out of scope doing that. Our third cohort is a cohort with high CK levels of creatine kinase. And this will require looking as a second tier assay. So we will be taking male newborn screening cards who have high CK levels and targeting for Duchenne muscular dystrophy. And then we will be comparing that second tier assay with a whole genome approach, and with a possible extension of looking at anonymized cards with a high CK level to see whether we can expand to a broader neuromuscular panel. Our fourth cohort is, again, a retrospective cohort. This is to take patients who have gone through the acute care whole genome sequencing approach. And the key question is here, could we speed up that acute care diagnosis if that data was already available? And so we could just basically switch it on and look at a broader set of genes to understand why that child might be in an intensive care bed. So this will be comparing singleton data against the acute care trio analysis and seeing what would be the reduction in yield. And our fifth cohort will require qualitative data, and this is going to be a consented cohort of mothers who will be working closely with our other GenScan partners for a national approach and seeing what would genomic screening in the newborn period look like? What's the information that we require to give proper consent? How much is too much information? How much is too little information? And when should we be consented? So this will look at 100 expected mothers, and we'll be looking at the questions such as performance in real time, attitudes, consenting, counselling, acceptability, logistics, and working through those. We are working to capture our data. Data security is an incredible importance, and so we need to be looking at these questions. Our data will go into the New South Wales Health Polos system, and we'll be able to keep that quite secure there. One of our key things is to actually work with our national colleagues. And in the MRFF grant, there were 5 funded projects. And collectively, we've formed a national consortium to work together so that we're actually working in a national approach and collaboratively. So there are 5 projects, 4 of them involve laboratory work, and a 5th project, Sarah Norris's project, is actually looking at the ethics, equity, efficiency, and equality of that. So these projects are all working together and in a very collaborative way. So within GenScan, we've created a steering committee, and then we have 6 subcommittees, which are to look at different aspects there. So there's a technical committee, what's the best way to create whole genome sequencing, bioinformatics, how do we process this large amount of data, clinical, what are the gene sets that we should be looking at, the ethical, the legal, the social impacts, the LC group. There are many stakeholders in this environment, patient groups, the general public, industry. So we need to work at that. And clearly health policy and economics are a huge part of that. So I'd like to think in terms of newborn screening that there are 3 major challenges. Technical challenges. There are certain genes that we can't actually, using short read sequencing, actually detect. Can we do it at speed and scale? And then clinical questions. Are there treatments? What's the pathway of care for each of these treatments? And each of these has more questions than just these. And then there's the policy questions, equity, priorities, what can we fund, and the health economics. So there are a number of challenges that we need to address, and I'll just let you have a quick look at those there. But there is a task that we're all learning, and we are working with the international consortium as well to try and address these questions. So we're working with a number of partners here, and it's a fabulous project, and it's great to be working with everybody there. So I just want to thank you for your time. And this is the list of our chief investigators and associate investigators in a fabulous group of scientists, ethicists, bioinformaticians. So now I'll hand you back to Michelle.
Thank you, Bruce. And thank you to everyone for the wonderful presentations, and thanks to those who have submitted questions. I would like to now introduce Dr. Laura Fawcett, who's the respiratory consultant and advanced therapeutics, or I should say, sorry, clinical trials medical lead at Sydney Children's Hospital, Randwick, who will facilitate the Q&A session today.
Thank you, Michelle. And just a reminder to pop your questions into the Q&A box, and we've got a few in already, and I'll just start with the first one that's directed towards yourself, Sophie. This is a comment and a question from Michelle Frost, who would love to review your publication when it's available, and is asking about the analysis. So did you do univariate sensitivity analysis around duration of the model, i.e. 10 or 20 years?
Okay. Thank you for the question. The SMA modeling study has been published in 2021. Just checking. 2021, we published the study in the Journal of JNMP. I can post the link of the publication in the Q&A after the questions. So basically, no, we did a sensitivity analysis, but not on the time frame of the analysis. The reason we chose 5 years and 60 years was the 5 years was based on the clinical efficacy evidence at the time of the pre-symptomatic treatment, mainly from nusinersen pre-symptomatic treatment by a number of clinical trials at the time. So that gives us some confidence about the treatment effectiveness of the pre-symptomatic treatment. And the 60 years is generally based on, lifetime for the long-term outcome. And the reason for 60 years was based on very old observation that in the past, SMA patient, their survival was about 60 years. So it can be done for 10 years and 20 years in terms of different timeline of the analysis. So, but in our work that we did not do that different time frame of analysis, but it can be easily done and just rerun the model.
Thanks, Sophie. And then next question is up for Bruce. So Susan Badman has thanked you for your presentation and is asking about the ethical implications or kind of considerations maybe of using de-identified newborn screening cards to rescreen and potentially finding an actionable variant, kind of asking about how that's planned to be handled in this study.
Okay, so using de-identified cards, we won't be able to go back and report any additional findings, or because we won't know who they are from. So that I think is the reason why we would take de-identified cards. We would only take cards where they've actually consented for de-identified research. So that is part of the current consenting process for newborn screening. So those would be the things. For those in the other cohorts who we've consented, then there is that potential to take things back. But for the 1,000 de-identified cards, it's not possible. And that's the advantage of using those cards. And it would be a good, in a sense, set of data that we can use for, if there are new therapies coming up, if someone offered saying there's a therapy for this and these are the genes we need to sequence, then we could actually use that data set to see whether those genes are well covered. Are we able to cover those genes? Though you would need to actually bring in probably an extra group to actually show that we can pick up variants, pathogenic variants for that particular disorder.
Thanks, Bruce. I've got the next question. It's got a few people wanting it to be asked, and I might put this to Sandi first, and Bruce, you might also want to chip in asking about, do we know of any other genetic conditions that may benefit from the current newborn screening gene therapy paradigm described that are not currently in the Australian newborn screening program?
That's a great question. I think the one that is a hot topic at the moment is, and Michelle Lorentzos will have views on this as well, is Duchenne muscular dystrophy, because there is an FDA-approved gene therapy, which is coming to the fore in the US, and there are trials going on here as well. And there is, even though those interventions are in childhood, if they work and they're safe, the age for access will drop, or may drop. So we need to be getting ready in parallel with the therapeutic sphere to be able to diagnose these children as early as possible. So I think the next area for at least neuromuscular is newborn screening for Duchenne muscular dystrophy. I know Michelle Lorentzos, Michelle Farah are doing a lot of work to try and establish at least a pilot program in New South Wales and ACT. I think the lessons from SMA is that we have to horizon scan because the therapeutics are evolving so rapidly. There are about 3,600 precision therapies out there in various stages of trial. And what we can't have is that happening in one sphere and us not being able to diagnose our children early so that they are research ready, and have the opportunities to get engaged in that research. So we've got to concurrently horizon scan and plan, and newborn screening is a beautiful model to help diagnosis for a certain population of children. Bruce, I don't know if you have any other ideas, or Michelle.
Yeah, no, certainly. I think the Duchenne muscular dystrophy is an important one, and that's why our cohort 3 is a DMD cohort, or potentially a DMD cohort. But I could also just add that at the moment, the Baby Screen Plus, which is the Victorian program, actually has 500 genes in it. So there are 500 potentially treatable genetic disorders that are there. Now, clearly, that's going to need to be addressed on many levels in terms of particularly around policy. But there are a number of what's called the treatable is actually expanding rapidly, and we need to be ready. And this is why we've gone for the whole genome approach, is because it allows us to, rather than one gene at a time, adding a new test, one test at a time, we can add multiple, basically to be ready for that.
Thanks, Bruce and Sandi. And the next question, you may not be able to give us an answer, but I think everybody will be curious about the panel's thoughts. So this has got 5 people asking, who are very curious about the impact of expanded newborn screening on genetic counselling services, and worried that they will be in high demand, and are we going to need to train up a whole load more of people who are experienced in genetic counselling? I'm not sure whether Bruce wants to take that first, or whether you'd like to tag that off to somebody else.
Yeah, I think it's going to be important. Counselling, I think obviously, the initial consenting is probably going to have to happen through the midwives as such. But as we identify, positive cases, then they will need to be addressed and looked at that. So I think that's a really important part of the research, is exploring the clinical pathways, and are we actually ready for that? And I think that's going to be why I think the rollout has going to probably have to be fairly cautious, that we don't overwhelm clinical services. If we keep identifying people, and particularly we need to make sure we have a very low false positive rate, because if we're pushing people out who don't actually have disease, then we're actually going to be probably, again, doing more harm than good. But clearly the clinical pathways need to be worked through. And there are going to be, I think, cases which need to be treated, where clinical geneticists, genetic counsel is going to be important, but a lot of it is going to be probably becoming more in that mainstreaming of, in terms of the therapy pathways. And I think each of the sub-disciplines is going to need to be working in this space, how to deal with these issues.
Laura, can I'm trying to discipline myself as a chair to not give answers to these things that are kind of close to my heart and where I work as well. But I think that's absolutely right. We need to be thinking about the clinical pathways and models of care, and making sure that we advocate for the resources and systems around that. But I also think we also need to acknowledge that in newborn screening, we are also, part of the aim of this is to decrease the journey that families go through in going to see multiple care providers, utilising allied health that's not fit for purpose. And so and these are children who would eventually be developing symptoms and often having genetic diagnoses made and seeing genetic counsellors at that point as well. So I think, we are moving the genetic counselling ideally to be earlier on, so we can have intervention, and we absolutely need to plan for that. And I'm not at all negating that point. But I also think that we're also ideally saving patients seeing multiple other providers and caregivers on the search for conditions. And there are many, many stories of patients talking about that diagnostic odyssey. So it's complex, but I think that there's also both sides to that point as well.
Thanks, Michelle. I'm trying to discipline myself from asking you the questions as well. But thank you for chipping in. Sophie, I'm going to take us back to the health economics couple of questions, and I apologise if I misinterpret them because it is not my area. But you have a question here asking about the cost model was undertaken from a societal perspective, but you've presented mainly the medical costs, and whether you're able to make some clarifications around that. And then some questions about kind of a small QALY number for when the newborn screening was incorporated, and how you make sense of those small numbers.
Okay, thanks for the question. So in terms of the cost, we did include everything, from societal perspective. So that in our Markov model, we simulate the annual cost of all the costs, including disease modifying treatment for nusinersen, especially they require ongoing treatment for nusinersen injection, direct medical costs, informal care, and also parents' loss of productivity to care for SMA children. These costs were based on a study led by Professor Georgina Chamber and published in 2020 in Neurology about pre-nusinersen economic and health-related quality of life burden for SMA. So again, this is kind of the best cost source we can use in our model, but may not be precisely a precise reflection of the SMA cohort under the newborn screening era. but it's a reflection of what we can get for the SMA when we're modeling the future cost. So they are actually included, especially the informal care and parents' loss to productivity. In terms of the quality, so the small numbers you can see, so in the presentation, for the treatment, the cost is presented in millions, and the quality is presented by per one SMA diagnosed baby. So the quality for the symptomatic new senescent baby treatment, new senescent treatment with SMA is 6.71 quality. And remember, these are discounted qualities, which is all the future life years and quality of life quality are discounted to the reference year, which is 2018. So our one-way sensitivity analysis actually show the discounting rate play a role in determining the ISA and especially in determining the cost and the quality. When we look at the future cost and outcome and discount it to the present value. But for the new senescent, for the treatment strategy embedded into the newborn screening, we report the cost and quality in one baby in the general population because we screen every baby. So we report the result for per newborns in the populations. Therefore, the quality is so tiny because SMA is such a rare condition that you only have prevalence of 1 in 10,000 newborns. So therefore, when you calculate back to every newborns in the general population, you model, then the quality becomes so small. That's basically the reason of that small quality numbers.
Thank you, Sophie.
No worries.
We've got a question here from Chris Elveridge for Bruce. So in terms of ELSI research in your project and other GenScan members, will the research be focused on only genomic aspects such as data privacy, or will it extend to aspects that would be agnostic to the technology used for screening? So maybe screening for conditions that might not have a treatment or those that have a later onset. So Chris is from the Childhood Dementia Initiative. Yeah,
so effectively, it is going to be around treatment, treatable disorders. So that would be what we would be aiming to do. What was the first part of the question? Sorry.
She's asking about in terms of ELSI research in your project and other GenScan members.
So the GenScans, for example, each of the studies has a strong LC component, but particularly Sarah Norris's project has a very strong LC component, and there are many overlapping investigators. I'm an associate investigator on Sarah's project. She'll be taking things like a community jury, so where effectively they choose 26 people from the random population and then presenting evidence to them to seek their opinions of what is acceptable. The study in Melbourne will obviously, as it consents 1,000 women for their study, they'll be looking at those issues of acceptability and things like that. We are working closely with each of the stakeholder groups, so patient groups and things like that, and looking to seek their opinions as well. So there's a lot of engagement there. The LC component is a huge part of this. And clearly we don't want to degrade existing newborn screening. It has huge public trust at the moment. 99.8% of people consent for newborn screening. So if we add in genomic sequencing and we actually degrade that, then we've actually done harm. So that's a really important point. And what we want to do is maintain the center ground. We don't want to polarize into two groups, those in favor, those, against that.
Thanks, Bruce. And I might just follow up with a question about the logistics of the newborn screening. So asking whether you can perform genetic and whole genome sequencing on the dry blood spot card, or is this going to involve an additional blood draw for patients?
So no, there is quite already accepted usages of getting whole genome sequencing off a dried blood spot. So while technically I think each of us are each of the groups around the country are working towards that. There are a number of studies overseas that have already achieved this as well. So technically it's very feasible. There are nucleated cells in that dried blood spot and a reasonable amount of DNA. But that's certainly, I think, one of the things we're all going to be exploring is, what's the success rate? If we do 1,000 cards, how many will we not get a decent genome out of? And we want to, that's one of our key things, is comparing, the genomes that we get out of newborn screening cards compared to the genetic results we get off a blood sample. But we feel we can do it. It's technically very feasible, and it is becoming a part of an international approach around the world. The UK are going to do 100,000 cards.
Thanks, Bruce. And Sandi, got a question here about the cutoff age for accessing treatment, and they've asked about specifically SMA. So is treatment available for adults with SMA2 and or SMA3?
So the treatment cutoffs are quite dependent. So there's three disease-modifying therapeutics: nusinersen, which is intrathecal administration, and gene therapy, and risdiplam, which is an oral, small molecule SMN2 splicing modifier. And all of them have quite specific TGA and PBS approvals regarding genotype, symptomatic status, and what else is there? And age as well, age cutoff. And the landscape changes, every 6 months as they try to push new approvals through. For the adult population, there is so the adult population so over 18s did not have recourse to therapeutics till very recently, but there has been an exciting development in that nusinersen has now been approved for symptomatic adults. TGA approval, I'm not sure if it's currently on the PBS at the moment. There is often a lag time between TGA and PBS approvals, but that is the newest development for the adult sphere. But the others are available in varying guises for our paediatric population.
So Laura, we have time for one more question.
Thanks, Michelle. I'm not sure if Bruce is having technical issues. I can see you twice online.
So I'm not quite sure what happened there.
We can hear you and we can see you. But you might like to take the first part of this question, which is, as there's a likelihood that the informed consent will be obtained by midwives, have the universities been contacted to have these types of conversations about future curriculum? And then Sandi, I might ask you to round that question off with a similar kind of frame of mind in terms of SMA and the therapeutics. Are these all being incorporated to future junior trainees and staff and our medical students and other students coming through the centres?
Yeah, no, education and training and of midwives is a very big part of our ELSI project. One of our chief investigators, Nazrin Javed, is a midwife, a clinical midwife who's trained in genomics. So she'll be really working very heavily on that. And that's one of the things that we're actually bringing to GenScan is a newborn screening approach, a midwife's education piece to that. Whether that's through the universities or whether that's through other training systems, I will take advice on.
And I'll just finish that question, Laura. I think we're trying to get the word out. I think what I would really like to see is people getting, our junior medical colleagues getting more and more experience with clinical trials and clinically embedded research, because we get to specialist stage and some of us have never been principal investigators, chief investigators, and then more and more our workload is how to get these precision therapeutics, how to get early diagnosis and put that into the clinical sphere. So I really think that there should be and will be a move towards having that research component really going hand in hand with the clinical sphere, people coming into our clinical trials unit as registrars and fellows, getting that experience, because I think that's the only way that we can train the future generations. I don't think it's just about SMA. I think it's just across this platform technology.
Thank you so much. We've run out of time, and what a positive place to end, really thinking about the challenges that we're facing in newborn screening, but also the potential. And I think 15 years ago, we didn't know that SMA would be treatable. We're on the verge of having treatments for DMD. There are currently clinical trials underway for conditions like Batten disease and adrenoleukodystrophy. So what we are able to screen for, or what we should be screening for in the next 5 to 10 years will probably look different to what we do now. So having a system that's robust, but also agile enough to make changes is so important. So thank you everyone for your excellent questions and for joining us today. The video of the webinar will be available on our website at the Sydney Children's Hospital Network YouTube channel. There will also be a short survey at the end of this, so if you have a moment, please fill it out, as we appreciate your feedback. Thank you again to our panel of experts for a fantastic webinar today, to our Q&A facilitators, facilitator Laura, and to contributors including Luminous Alliance, and most importantly to the audience for your active participation. A special thank you to the staff at SCHN who have supported today's presentations. Stay tuned for our next webinar by subscribing to the Research Interest Group mailing list using the QR code on the screen. We look forward to having you join us then. Goodbye, and thank you again.
Thanks, Michelle.